Ma'am, who else is there from the office bearer sides, ISP head office?
Me.
Only president all the time?
मैं सर मैं हूँ
Oh
सर मैं
yes,
हूँ
yes, yeah, Neeraj is there,
ये
yes.
मत भूलो
नीरज के बगैर तो चल ही नहीं सकता ये।
नहीं मैम ऐसा कुछ नहीं।
नहीं
ये live on YouTube.
11 बज गए, मुझे लगता है हम शुरू करते हैं।
Yes ma'am. Yes, permit others and we'll start.
Yeah, I will admit all.
All the best, Sana.
Thank you so much, ma'am.
All the best, Dr. Sana.
Thank you.
All the best.
Thank you.
Okay, now you can start, sir.
Should I start the lecture?
Let me introduce
Baljit
you.
sir will
Dr.
intro.
Okay, okay.
First Baljit sir will introduce.
Okay.
So shall we begin?
Baljit sir, you can start.
Okay. So very warm good morning to all of you. Now, first of all, I acknowledge the presence of our worthy President, Indian Society of Periodontology, Dr. Nimpya Pandit. Now, I thank you, ma'am. Thank you so much for giving me one more opportunity to share this platform, this prestigious platform, rather, I would say. And that too for moderating a scientific session of a very, very reputed speaker. Now, see, when I began my career as a dentist, lasers had, what I will say, that they had a very limited role and applications in the field of dentistry. Okay, now today when I look back and see this field, it has grown by leaps and bounds. And you all will agree with me that the credit for this goes to a number of hardworking people worldwide who have made this field so popular amongst the dentists. And one of them is amongst us today. Now see, you will find that during the conferences, there will be some charismatic phases, some charismatic speakers. You can't take your eyes off. And on the other hand, guys like me who will put you to sleep immediately. And today we have got that pretty face, that charismatic face with us today.
I think this is the best introduction, I guess.
Who will keep us all busy throughout the session. Now see, the resource person for today's session, what I feel doesn't need any introduction, but since it is a customary, I need to introduce you. The speaker for today's session is somebody who is a diplomat in laser dentistry from Germany. She is also a fellow in laser dentistry from USA. She has done masters in microscopic plastic, aesthetic periodontal surgery, and perio-implant infection management from Bern, Switzerland. Of course, as you all know, you will be knowing when I introduce her name. She is a world-renowned speaker. She keeps on moving from place to place, delivering lectures, having so many courses on laser dentistry. And something good to her credit is that she is a founder of what you call as Divas in Laser also. Okay, and what I've been told is that she is the one who has got a magazine published, probably the first fashion magazine in dentistry regarding laser and aesthetics. And something very, very creditable to her CV is that she has been listed in the top 100 influential women in India by Forbes India 2020. So see, if I show you this, there is a big list of all her credentials, but it will take a pretty long time for me to introduce that. So not wasting much of your time. It's with great excitement and I'm pleased to welcome Dr. Sana Farishta to this webinar. Sana, this is all yours. Please begin with your presentation. Thank you so much.
And thank you so much for this humble introduction. I am full of gratitude. I really want to thank my ma'am. Because of her, today I'm here. And also want to thank Neeraj sir and the entire ISP team, because I think everyone is my favorite. And I think I am everyone's favorite too in ISP. And yes, thank you so much for this opportunity. I can never say no to any one of you. No matter I have to cancel my patient or do anything, but I'll never say no to any one of you for ISP. Okay, let's start. Okay, so I am not going to bore you with the physics and all, because I know most of us know about the physics, because we are periodontists, and this is part of laser is now a part of curriculum, and we are very much familiar with the physics and all. So I'll just take 2 or 3 slides to introduce you guys about the physics, but yes, followed by the lecture. Can I go and yes. Ma'am, the panel on the sides are visible, or it's just the slide?
Yes, yes, yes. Yeah, it's visible.
I mean, like, then I have to hide myself and
Yeah.
you people?
No,
Oh,
no,
I
you have to
wanted.
hide. Yeah, you have to hide
Okay,
yourself.
I will hide. Otherwise, I was so happy to see you guys and talk. At least I can see ma'am and talk.
No, but otherwise it won't be visible. Yeah.
Yeah, I will do that. I will hide it. Yes. Now, okay?
No, it's visible. Yeah, it's fine. Now.
Yeah. Yeah. I'll hide it somewhere here. And yes. Okay, let's go about it. Okay, I want to thank every one of you. I think I can see 194 participants and still people are coming. And yes, guys, I am open for questions. Any questions you can ask me. Let's start with lasers. So what are different types of laser? There are 2 lasers, as every one of us know, soft tissue laser and a hard tissue laser. So example of soft tissue laser is a diode laser, what we use regularly, a small portable machine. And another hard tissue laser example is erbium, which is a little bigger machine and little expensive as well. So my question to you guys is, can you use your soft tissue laser to treat the hard tissue? And can you use your hard tissue laser to treat the soft tissue? When I say soft tissue, what are the soft tissue inside the mouth? Gingiva, tongue, buccal mucosa. And when I say hard tissue, what are the hard tissue inside the mouth? Tooth and bone. So my answer will be, I cannot use my soft tissue for my hard tissue, that is my tooth and bone. But of course, I can use my hard tissue for my soft tissue procedure also. And that's why the hard tissue laser is known as all tissue laser. Clear, everyone? Now, let's go to electromagnetic spectrum and the physics. And when you see the physics, very important thing is, there are 3 portions to it. One is UV light, another is visible light, and third is infrared light. Now, this infrared is again divided into 3. The closest one is near infrared, the middle one is the middle infrared, and the far away is a far infrared. Very important, what we use in dentistry regularly, diode laser falls in near infrared, right? Yeah, this is my cursor, near infrared. So near infrared, what are the wavelengths? There are 810, 940, and 980, right? These are the regular wavelengths available in the market. I am talking about the history. Now, laser is a history as well, but today I'm gonna give you good and very new things into it, which is very latest. So I said near infrared. So near infrared, that means it has no color to it. When I say visible, that means there are color to it, right? So the diode laser, what we use regularly in dentistry is in near infrared, which has 3 wavelengths. I repeat again, 810, 940, and 980. When we talk about hard tissue laser, it is middle infrared over here, and it has 2 family. Erbium has 2 family. Erbium YAG, erbium chromium YSGG. And you can see the wavelength. The erbium chromium YSGG has 2780 and erbium YAG is 2940. Okay, nanometer. Now, as I was talking to you guys, whatever the machine have you seen earlier from like before 2 years, all were a machine with a single wavelength, a diode machine with a single wavelength. Now I'm talking about a diode machine with a triple wavelength. So let's focus. So you will find a diode machine which has triple wavelength, which has like 980 infrared, or they can also have 940, any one of the one wavelength from infrared. Then there is 650, which is red in color. Why 650 is red in color? Let's go back to the electromagnetic spectrum, and you can see here visible light, and you can see the range over here. So 400 to 750 approximately is under visible light. And when I say 600 over here, this one, see, can you see? Maybe this here area, it is red in color. And that's why 650 is red. Okay. So it has 650 in it, and also it has 470 in it. Some people introduce 470, someone has 450, different brand, different wavelength. Okay. So, and this 400 wavelength over here is blue in color. Right? So one diode machine will have 3 wavelength, and that machine might be known as blue laser or blue light laser. Why? Because the dominant light in it is going to be a blue in color. Right? So now my personal favorite now is a machine which has 3 wavelength, where I can use 650, 470, and 980. So till now, whatever procedure we are doing in dentistry with diode laser is we are contacting the tissue and doing it. Let's say frenectomy, let's say depigmentation. What we do, we touch the tissue and then when we do it. And what if I say that, you guys, that you don't have to touch your tissue, you can be in a non-contact mode when you are using a blue light. It can be 450, 470 and do your surgical procedure exactly like a hard tissue laser. So when you use a hard tissue laser, you are almost not touching your tissue. That means you are in a non-contact mode or a slight touch. When you're using your hard tissue laser on a soft tissue, non-contact or a slight touch. When you're using your hard tissue laser on a hard tissue, like for tooth preparation, for maybe like cavity preparation, for the osseous crown lengthening where you have to cut the bone, everywhere it is non-contact mode. You are not going to touch it. Okay. The same thing, you can do it with 470 or 450. And what is 650? Why 650? So 650 is good for red light, is good for photobiomodulation, right? So we have a machine which has all the 3 wavelength, which is available from different brands, and you can use it as non-contact mode when you're doing a surgery with 450 or 470. You can use your photobiomodulation with 650, right? And you can use it for your endocanals debridement or periocanal debridements with 980, 810 or 940 respectively, whatever the company is giving you. Okay. So these are the machines which maybe it will be present in your college or maybe in your clinic, or maybe you have seen these machines. These are again a soft tissue machine. So each machine have only one wavelength to it, right? And those wavelength can be 810, 980 and 940, and these are in near infrared wavelength. Am I clear to you? Am I audible to you? Yes? Now, this is again a machine which has... Thank you so much for the response. Otherwise, I was thinking, okay, I'm just talking to my laptop. So this is another machine which is like compatible, and this also has only single wavelength to it, right? But there are different machines in the market which has this kind of a machine which has like triple wavelength to it. It is also in a form of dense ply, which is giving a blue light laser. It can be peon, it can be woodpecker, anything. These are the brand names. So these are the triple wavelength machine available in the market, right? So it has blue light, red light, and infrared as well. So this is the latest advancement in laser. And yes, I have done almost like 5 studies till now, which will be published soon with a blue light laser, where you can see the difference between the blue light, that is the wavelength specific I'm talking about, and difference between what we are doing since ages, that is infrared. Okay. So why my personal favorite laser? Because it requires minimum instrument. I can not even, sometimes I don't feel like using mirror also. I can still use just my laser machine and my glasses and I am good to go. Now, let's start. This much basic was required for you guys. Let's talk about the treatment, how we do about it. So gingival depigmentation. So what are the different modalities when I talk about gingival depigmentation? First is scalpel, second is your burr, third is your electrocautery, fourth is your Kirkland knife, yes, and laser. So yes, we have cryo also and different thing, but here I'm talking about this. So this is pre-operative and I did lasers to it and that's how it look afterwards, right? Then let's talk about comparison between the burr and Kirkland knife. Very important when I do and when I talk about a depigmentation case, very important is like all my cases, what I do in my clinic are all of them are facing camera. Very important. So aesthetics is a prime objective for them, right? You ask your patient to smile. When a patient smile, you have to see whether it's a molar to molar smile or it's a premolar smile, and you will include entire gingiva. Very important. Why? Because you don't want, if you do a patchwork, like, okay, I can see melanine over here, it's too much, let's remove it. Do you believe in it that the new healed gingiva which will come will match with the color of existing gingiva? No one can guarantee that, right? So you have to remove the entire gingiva, including the marginal gingiva and interdental papilla, which is very important. So what you will do here is, I am using a burr, and on the other side, I'm using a Kirkland knife. That's how we finish the case. Periodontal dressing must, because there will be continuously oozing of blood, and also whenever my patient eats anything, it's gonna feel the spicy thing, like, and patient will complain about it, and that's why we give dressings. And this is how before and after. Now let's compare the scalpel and laser on this case. Here the scalpel and here is a laser. Very important when I am comparing scalpel and laser is, with scalpel you can use two techniques. One is a partial thickness flap. Of course, all of us are periodontists and we know about partial thickness flap. But yes, when I started using laser, I was not a periodontist. First, I was a dentist and a laser dentist, and then followed by a periodontist. So it was very, very difficult for me to raise a partial thickness flap, right? Including the marginal gingiva and the interdental papilla. It was like a tough job. Another thing is scraping technique, where you scrape the gingiva. So I love the scraping technique because it's easy, it's not technique sensitive, and that same technique you can apply it in laser when you are using lasers. And that's how it looks like. And it's a 2-year follow-up. Again, with the electrocautery. And I've used electrocautery for this, and that's how it's a follow-up. And guys, very important. Why I feel that I am biased about laser, because there is no bleeding while I'm working. And very important is my patients love it, and they come back again and again, like a bleaching case, like a scaling for depigmentation, because no matter what treatment modality I'll use, laser, scalpel, burr, electrocautery, there is going to be a recurrence. Nobody can say there will be no recurrence, because it's a continuous process. It's a physiological process. There is a production of melanin by the melanocytes. And of course, I'm sure all of you are aware of migration theory, right? Or should you want me to talk about it? Let's talk about it. So what is migration theory? So if you are doing a depigmentation from molar to molar, and there is a melanocytes which are sitting in second premolar gingiva, they have a tendency to travel. And they travel and come to the site where you have done depigmentation, and they start depositing melanin. So this is going to be a continuous process, but yes, the intensity is going to be decreased. But you have to talk to your patient accordingly. They're like bleaching and scaling. You come for 6 months, you have to come for depigmentation. And if your patient is smoking, then the tendency of recurrence is more, because what kind of a patient I treat, 99% of them are smoking. Okay, so it's an aesthetic procedure, and you can ask your patient to stop smoking, but you can't force them to stop. But yes, of course, this is like bread and butter for me. So every 6 months, I have like almost I think more than 50 patients who comes for me for depigmentation, bleaching, and scaling. Cool. Another thing is that what I like about this is I don't give dressings after my depigmentation and no injection. So if I'm not injecting for my lasers, of course, I'm using a topical anesthesia, which is very important, right? And topical anesthesia, very important, is if you say that I have in my clinic or in my department only 2% of lidocaine, and do you expect that 2% to work on the patient? It's a myth. I think it's not going to work. Guys, you have to understand you have to use more than 10% or maybe 8% of procaine, benzocaine, or maybe 15%. The more amount of anesthesia you're using, the better is gonna be act. Okay. So these are the few things. I'm sure you have gone through the charts. Now let's see how we do it. Because see, whenever I talk about something, for me to remember, even if I am sitting in, listening to someone, it's very important that the person just not talk, but show some videos. So here is the case where I'm doing this is the case where we're doing a partial detection phase. Can you see in this? And then I will show you on the contrary, on the other side. Very important when you're using laser, you can bend the tip, and you should bend the tip and go by. And what is important is no matter you do circular motion, you go zigzag, or centimeters, whatever. End result should be there, should be scraping and removal of the epithelium and the parts. Okay, there's one more video to you guys, and I am sure you're gonna understand.
Hello everyone, I'm Dr. Sana Farishta, periodontist and a laser specialist from India. And today we're going to talk about depigmentation technique using 980 wavelength with S1 Pion laser. First of all, you will select a patient and ask the patient to
Same
smile.
thing what I mentioned.
You will cover the entire gingiva which is visible when patient is smiling. And the next is you will now select a 400 micron tip, which is a surgical tip. You will initiate the tip and then start with a gentle brushing stroke from the one side of the mouth. Remember, you have to start from the attached gingiva and then come down towards the marginal gingiva and interdental papilla. Another thing is that the wattage what I have used here is ranging from, you can start with 0.5 watts and go up to like around 1.2 watts in continuous manner. And in this patient, the wattage I used was 0.9 watts. So all this depends upon the content of melanin in the pigmented area. And that's how you will do a depigmentation. You will exactly follow the steps and the motion what I am doing here, like a small gentle brushing motion, and you will scrape the epithelium and a part of connective tissue, making sure that you don't expose the bone and a part of connective tissue is still there intact. And that's how you will do a depigmentation technique with 980. Thank you, everyone. Whole life.
Yes, so this is the post-operative view of the same case where I use 450 on the upper one and 980 on the lower one. You can see it's one of the picture from the study, which we are going to publish soon. Yes, so drawback of scalpel. What is important for me is bleeding during the surgery, and I hate periodontal dressing, except for the root coverage procedure. Yes, I have to use it. And why lasers in dentistry? Why I feel lasers in dentistry is less post-operative swelling, less need of suturing, less need of local anesthesia, less post-operative pain. I will always say less. You will never find me saying that no need of anesthesia, no swelling, because I think that's a little exaggeration. So it's always less. And the reason behind it, why bleeding is less with laser, because laser increase the platelet activation at the point of wound, which leads to sealing of blood vessels. Very important, guys. You note it down. If I am your examiner, I'm going to ask you for sure. Why swelling is less with laser? Because it seals the lymphatic vessels. How bacterial load is reduced with the laser. Very important is laser goes and attack the chromophores, that is melanin and hemoglobin. And also the pigmented bacteria have chromophores to it. It attack, it get absorbed in the bacteria, and that's how it kills the bacteria. Why suturing is less? Because bleeding is less. And of course, we can do a laser welding, that is laser suturing. Very good and very well. Yes. So let's talk about non-surgical periodontal therapy, where diode, what I can do with the diode laser is removal of disease pocket lining epithelium, bactericidal effect inside the periodontal pocket. What I cannot do with the diode laser is removal of calculus and root surface detoxification, right? But yes, I can do this with my hard tissue laser, right? Yes, we all of us being a periodontist aware of this scenario, healthy, mild, moderate, and severe. Let's go and talk about curettage. Laser curettage, also known as laser debridement. Guys, if you go ahead and see and find out the article or Google about laser, you will find 10,000 new terminology used by the companies. Because what happened is, these terminologies are actually used by the doctors who are supporting the companies, and that's why there's so many terminologies, but the procedure is almost same. So what they are doing in laser curettage is exactly the same what you're doing with laser debridement, but the names are different, so don't get confused with the technique. Another thing is that the curettage term has been removed from the periodontology already, and that's why I like to stick to laser debridement. So let's talk about what people are saying. Let's talk about what article says. Let's talk about what the entire world is saying. Let's talk about what all speakers talk about laser debridement, and then I'll tell you what I like to do. Okay. So they say that first step when you do a debridement is very important is measure the periodontal pocket. Yes, this is mandatory. And second is gold standard, which is scaling and root planing, of course, and then you will use your laser. These are the three basic things that needs to be very clear in your mind, right? So first we will measure the periodontal pocket, and according to the research, they say that you have to keep 1 mm short of the pocket. What? Your laser tip. That is the fiber optic wire. The laser tips need to be 1 mm short of the pocket. Then you go inside the pocket in a manner like this, zip, 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 and then you come out, okay? And make sure that entire epithelium is reduced and you are ready and finished with the procedure. So my question to all those people is, the first question, how do you measure the pocket? You will measure a pocket like a walking of a probe, right? You will walk the probe. And do you think your mesiobuccal pocket is equal to distobuccal pocket? Do you think those two pockets are equal? No. All the 6 areas you will find different pocket size. So do you think clinically it is practical that for each tooth 6 times you probe it and then keep it short of it? And it's such a small pocket like 4 mm or 5 mm where we do a curettage procedure. You can go and zigzag manner and you can keep a count of it. I cannot do it. Another thing is that what I don't feel is, maybe if I'm measuring a pocket, for me, it's a subjective thing. For me, it is 4 mm, and my sister is measuring a pocket. Maybe for her, it is 5 mm. And who knows? God knows, only God knows what is right pocket. So what if it's actually 4 mm and my sister consider it 5 mm and she keeps it at 4 mm? That means she's actually at the base of the pocket and she's creating a pocket. Don't you think so? I think, yes, I'm making sense to it. Yes, of course, yes. And that is the reason why when you see a lot of literature, a lot of studies in perio, they will say that, yes, I think laser debridement or laser curettage has a negative impact because that is the reason. When I have gone through and read and every studies, there are a lot of points to, I can be critical about it, what is wrong about it. So what I believe is, whenever the laser react with the tissue, there are 4 things which happens. First is reflection. Do you need reflection? You don't need a reflection, and that's why you wear a safety glasses. Second thing, what happened is absorption. Do you need absorption? Of course I need absorption, and that's how the laser works. Third is transmission. That means it goes away out of it. That means it's doing no work, and it's okay with me. Fourth is scattering. Do you need scattering? I need my scattering. I need scattering for my periodontal pocket. I need scattering for my photobiomodulation. And what I do in my case, if there is a pocket, what I do is I don't finish my treatment in first sitting. Very important gold standard. Because if you are doing, you are a clinician or you are doing in academics, whatever it is, you have to call your patient again so that you can see the subgingival calculus. And that has been taught to us by all our respective, my guide also. My guide was Dr. R.K. Eltivasa. And I'm glad and happy to have a guide like him. So yeah, I really wanted to thank him also. So this is what, very important is, so I will call my patient again rather than finishing it. And why I like to call my patient again and again, imagine my pocket is 5. Okay, I'm just imagining. I'll just go 2 mm inside it, not more than that. Because I don't know what is exact pocket. I want the scattering to do the effect, right? So how I will do it? I will show you a video. Guys, don't get confused because this video is also applicable to the next procedure, non-surgical procedure, what I'm going to talk about. So I have not done scaling over here, but when you do a laser curettage or a laser debridement, step 1 is measure the pocket, step 2 is scaling, and step 3 is laser. That's it, okay? Laser is acting as an adjuvant. Very important. See this. Always remember you're keeping your tip towards the tissue, towards the soft tissue, because you want to clean it. And what happened is you are only 2 mm, but your laser is going 4 mm deep inside. So you are taking care of it. When you call your patient again, you can repeat it. You can, and very important is then when you're calling your patient again, you can't check the pocket, right? Because you have to wait for a month to check the pocket. So at that point of a time, you have to arbitrarily take 1 mm out of the pocket and do it because you are sure that there will be some amount of healing below it. Yeah, it's all arbitrary. Yes, it is. Right? So if there is some amount of healing which will be inside the pocket. So you have to keep that in mind. And very important, this laser curettage and debridement is applicable in the areas where you will do a curettage. Acha. So you have a patient and you will feel, okay, I will do a curettage to this patient. This patient doesn't require a flap surgery. Fine. If you find those kind of a patient, go ahead and do a laser curettage. As simple as that. There's no rocket science to it and there's no different protocol to it. Right? Yes. Shani, can you take care of Nemo? He's making a lot of voice. Yeah. Can you just ask him to stop? Yeah. So post-operative instruction and maintenance is very important because we are periodontists and this is what our real thing come into picture, maintenance phase, and which is very important. The second is, sir, can you hear me? I'm audible? Nice. Going nice?
Yeah. You are audible.
Thank you, ma'am. Thank you, ma'am. I thought, ma'am, you are not listening. You ran away. You didn't?
Oh,
because I can't see you.
I'm here only. How can I miss you?
Yeah, it's glad to see you here. Okay. So LANAP. The next non-surgical procedure is LANAP, that is known as laser assisted new attachment procedure. Guys, if you are saying LANAP, it's being marked TM. TM means patented. So it is patented by some company. Which company? Which produces NDAC laser, Periolase, MVP7, Millennium Dental Technology. So mind you, you cannot use this terminology when you're doing the same procedure with diode. So that means you can't do same procedure with diode. Of course, you can do same procedure with the diode. It's just that you can't call it as LANAP. So what you call it as? You will call it as LAPT, laser assisted periodontal therapy. Clear? Makes sense? So this is a company protocol. When you see the protocol, it says that it requires single session of laser treatment, removal of pocket lining epithelium, killing of the periodontal pathogen. So, okay, so company line, they will not say bactericidal effect. They'll say killing of the periodontal pathogen, achieving hemostasis, and all those things. Okay, what exactly it is, let me explain it to you. Step 1. Remember what I said for laser curettage and debridement. Stop thinking about LAPTA, right? Let's go back to laser curettage and debridement. What I told you, measure the pocket, scaling, and laser. Now, stop there. Come back to LAPT. What I'm telling you here is step 1 laser, step 2 scaling, step 3 laser. Again, got my point? This is used for deeper pocket. Step 1 laser. When you first step 1 use laser, you see in the picture here, when you use laser, what will happen? When you see here in the next picture, it will remove the entire pocket lining epithelium. Once the pocket lining epithelium is removed, why it is important to remove the pocket lining epithelium? Then you can see the subgingival calculus with your naked eyes. Better than how before the pocket lining epithelial removal. So it's much better when you remove it, and then again you will use laser. Then you will do scaling, and in the end you will use laser again. Okay, no confusion. Repeat again. First pass, that means first time laser, then scaling, then second pass, second time laser. You remember whenever we do a scaling, there is splattering of the bacteria. The bacteria may splatter from here to here because scaling is not a bactericidal effect, it's a bacteriostatic. That means it is just removing the bacteria. So after the scaling is done, you again need to use laser so that you give a bactericidal effect, which is very important. And this is one of the reasons why we do LAPT with diode laser. Okay. Laser assisted periodontal therapy. Clear, everyone? This 2 technique. There are almost, I think, 12 technique. Yeah, non-surgical periodontal technique. And mostly I use like 6-7 techniques. Yes, and I need like almost a month time to teach you all those things. And that's what I do in my fellowship. So yes, but I'm briefing you about few techniques over here. So why I like this technique, LANAP or /LAPT, because my favorite point is the last point. It loses the tissue, provide the good visibility and access for instrumentation, which is my favorite. Yes, postoperative instruction and maintenance is a key thing and very important when we say that we are a periodontist. Now, very important what you cannot do with your laser. Me as a periodontist, I will not say I can do everything with my laser. I cannot do with things with my laser is furcation area. I can't do my infrabony pocket. Of course, I have to open a flap. I have to put a bone graft. Of course, I have to clean it. And there is a pocket which is not healing, or it is persistent pocket after non-surgical therapy also. Of course, you have to keep your patient in maintenance phase and do a flap surgery. But yes, I am a big fan of laser and I'm using laser. So I am not doing a generalized flap surgery. It is always limited to a localized area. So let's see this. In this case, it is a endoperio lesion. I could, after the entire treatment, I could sense it. It required a bone graft. I put it and sutured it. In this case, the entire area has been treated with a laser. And then when the patient came for the maintenance, I could see, okay, there is a pocket. Okay, so there are 2 periodontists who work for me in my clinic along with me, because I just hate taking pockets and teaching patients about this. So there are 2 I love to do treatments. So one is Aditi, Dr. Aditi Chaudhary, and other is Dr. Rufi. And they both are the divas in lasers. So yes. So most of my pocket measurement and all is done by my two periodontists who are with me in my team. So here we go about it, and we placed this and we sutured it. That's it. Another thing is furcation area, right? So this guy, this gentleman also, I have treated him with the lasers, and after like 6 months or so, he came for the follow-up. And yes, very important, if I'm saying follow-up, if I'm treating 100 patients, 99 patient comes for the follow-up. I know how to call them. Yes, and how to, treat them, and what needs to be done, what we need to give them so that they will come back and everything, which is important. So here, the furcation area, we cleaned it, opened it, grafting, membrane, and here we are done. Right? So full flap with rather than, and then we do a localized area. Now operculectomy, very important. I said that I will never say that I have to inject not inject my patient when I'm using lasers. But of course, when I'm doing operculectomy, I will inject my special patient. Very, very important, because the operculum is thick and there is pain already. So don't place stunts and just ask your patient that nahi, main injection nahi dungi, and it will work. It will not work. In most of the cases, you have to inject your patient. I'll show you a video. So you're going to appreciate it more and more and more. Let's go about it.
Hola everyone, I'm Dr. Sana Farishta, periodontist and a laser specialist. Today we're going to showcase you a case of operculectomy in respect to 4-8. We are going to do operculectomy followed by restoration of the same. So before we start, I have selected my laser to be Pion S1 laser and the wavelength 450. What we will do is we will select a 400 micron tip, which is a surgical tip. We will initiate the tip, and then keeping it on 0.4 watts, I will give a marking around the area which needs to be removed. Once the marking has been done, we will go back and increase the wattage to 0.9 watts continuous, and then we will give an incision so that we will continue to follow the dots which has been given before. And after that, we will again go deep inside the tissue and remove the entire chunk of the tissue. Advantage over here is there is absolutely no bleeding, so that we can immediately follow it by a restoration.
Clear, everyone? Ma'am, you can hear me?
Yeah.
Cool.
Yeah, we can hear you, Sana.
Very clear.
Okay.
It's very clear.
Very nice.
Okay.
Going
Okay.
very well.
Thank you. Okay. Now, frenectomy. So when I was in my PG, what I used to do is I put a hemostat tissue, put one incision above it, one incision below it, remove the entire chunk of the tissue, and then suture it, make sure that I leave a raw area below it. And that's how we do a frenectomy with a scalpel, right? Now, what are the type of frenectomies? What are the type of frenums? Very important. Mucosal, gingival, papillary penetrating. Will you follow the same procedure what you do in all the techniques and papilla penetrating? No, you have to change the procedure, right? So there's a comparison between scalpel and laser. And yes, I have injected my patient, right? So that's how you do it when it is papilla penetrating, because I need to do my crowns, my laminates, want to close the diastema. I don't need that chunk of tissue over there. I leave it raw when I'm using laser. And that's how, followed by a temporary over there.
Hola everyone, I'm Dr. Sana Farishta.
So see, one thing I will tell you, all the students PG who are doing PG, very important thing, keep updating and upgrading. It's been so many years. I am like almost 11 years I have done lasers. But yes, if you see my presentations and if you see my videos, I'm going to show you my first video, what I did for this One Dental. So this video, which I'm going to show you, and you have seen my work before. The video is what I have shooted. And now when you see my work, which is going to come in next year, it's going to be above all of these videos. So please update and upgrade. That is only one thing which will keep you constant. You have competition with no one. You are your best competitor. So compete with yourself and do the best.
Hola everyone, I'm Dr. Sana Farishta here, periodontist and laser specialist. Today I'm going to showcase you a case of high frenal attachment, and we are using laser to treat it. So before we start any procedure, very important is how we do the test to check whether it is high frenum or not. To do that, we do a tension test. We can pull the lip, or you can use a probe to check whether it is high frenum or not. The moment you do that, you will see there is a movement of the papilla between the two central incisors, or there will be a blanching. That says that it is a high frenum. Exactly the same thing we are doing here in this patient. And once we see that it is high frenum, and then we will proceed it with the surgical procedure with the lasers. Here, before I start doing my laser, I have applied topical anesthesia, and I've asked my patient if the patient have discomfort or anything, that patient is going to tell me. So I will either apply the topical anesthesia again or infiltrate my patient, because I don't want my patient to have discomfort. We are starting with my laser at the base and then proceeding towards upward, making sure that I relieve each and every fiber. The best part is there is actually absolutely no bleeding here in my case. I can actually see all the fibers, and I can go ahead and relieve that fiber or cut it exactly where I can see. So many of my students ask me, Doctor, when should we know that the procedure is completed? So I will say that each time when you're doing this procedure, do the tension test. Once you see that there is any attachment on that area, you have to use your lasers and relieve it again and again. The best part here is, can you see in this patient, I have this diamond shape incision which is given, and I'm making sure that I have relieved all the tension over there so that it has a good results. And you can check again, and you do it again, and that's how you do it. Always use a high vacuum suction so that whatever the plumes come out from the laser usage, it is taken care of. And also it will cool down the area. Very important thing is that there should not be any carbonization or overcooked tissue. If it is brown, it's nice, it is acceptable, because when you cut with the laser, there are 3 layers: volume of cut, area of coagulation, and area of edema. The second layer, area of coagulation, looks like a brown thing. And the last picture here is a post-operative picture after 7 days, and you can see amazing healing in this case. Thank you so much.
Frenectomy. One was frenectomy, entire removal of the frenum along with its attachment. Frenectomy is just relieving of the frenum. We usually do it because there is some amount of recession which we feel on the teeth, and once we do it, the recession is taken care of as well. The same thing in this case, I have not injected. I usually don't inject. Vestibuloplasty, here is a comparison again with a scalpel and laser, and that's how we do it. And can you see the healing after 10 days? My laser healing versus the scalpel healing. Oh, Shani, can I have a charger? It says low battery. I forgot to put the charger. Yeah, help me with this. Sorry, guys. So Dr. Shannon is my sister, and she is also an endodontist, and works with me in the clinic and one of the divas in laser and one of the best speaker in endodontist when I don't know, it's not going inside. Maybe I have to remove this. Yeah. Take the pen drive, I think. Yeah. Fine. Let's go back. So this is the healing after 10 days. And I'll show you a video. Guys, this is going to be your first video, what you will see with a 450 wavelength, that is blue light. So in this case, either I am non-contact or slightly contact. Okay. The case what I've showed you, I have done it with 940, which has been published. And this is my new video, which I'm doing all the procedures in a non-contact or a mild contact. So just go by it, enjoy the video. And
Namaste everyone, I'm Dr. Sana Farishta, periodontist and laser specialist from India. And today we are going to talk about vestibuloplasty procedure using 450 wavelength S1P on laser. Before we start with the procedure, we will apply a topical anesthesia to the patient, and if required, definitely we're going to inject the patient. For this procedure, I have selected 400 micron tip, initiated with 450 wavelength, and also making sure that I keep the tip in a non-contact mode or a slightly contact mode during the entire procedure. I have selected my wattage to be 1.5 in a continuous mode. Once done with the procedure, you make sure that you either give a periodontal dressing or a suture to avoid the relapse. Thank you, everyone. Namaste.
yes, there is a case over here where I did a gingivectomy. It's a drug-induced enlargement case where I did a gingivectomy with scalpel followed by gingivoplasty with laser. And I still remember this case. I did in my PG, and thanks to my guide that he used to listen to all my nonsense and give me a, space to do whatever I want. And yes, here I'm measuring the periodontal pocket with a pocket marker, marked it. Of course, remember when you're doing a gingivectomy, external bevel incision, you will remove the entire epithelium. And then on the attached gingiva, we decided to scrape it, and we scraped it with a laser. Because the enlargement was also on the attached gingiva, and that's how it looks afterwards. And he really loved the case. And he's like, now everyone is doing like this because we are getting amazing results. Crown lengthening. Yes. So this is before and after. Very important when I talk about crown lengthening is the biological width. So I have also written a chapter in a book, which is known as Clinical Fixed Prosthodontist, which is an amazing book, which is very expensive, like almost $9,000. But yes, it has a chapter on perio, where I talk about the biological width and the temporary crowns, permanent crown, laminates, and everything, when to lute, when not to lute, what to do, what material to use, how much time we have to wait if we have a client which has a shoot next day, what to do, and which is a very critical thing which people, they don't know much about it and they are confused about it, when to give a temporary, when to give a permanent crown. So everything has been measured over there. Also, how to measure biological width is by bone sounding method, which is in our Carranza, and all of us follow it. But also I came up with a new technique, how to measure a biological width, which is also mentioned in my book, which I have written with a lot of, I think they in that book, it belongs to Moez Kakiani, and there are a lot of authors who have written it, and it's amazing, colorful pictures. So we have set, and we, in Adopt, we made each and every pictures, how to measure it and everything. The pictures are also our own, and it has amazing explanation if you want to see how it goes bad. Yes, so here the biological width according to Carranza is 2.04 mm. I always keep a leverage of 3 mm. I keep it 3 mm so that to be very safe. And if you don't respect the biological width, what will happen? Either there will be recession or there will be inflammation of the tissue, which I really don't want, especially if I'm giving laminates. And if I see there's a lot of inflammation above it, I will see that my case is actually a failure. So I always, when I'm doing crown lengthening, aesthetic crown lengthening in anterior teeth, I will show you one of my case where I did a closed flap osseous crown lengthening with a hard tissue laser. I always make sure that I do a osseous crown lengthening and make sure that the biological width is intact. So there's a video over here. You can go about it. These are the 3 steps which I follow, and this 3 steps is my favorite step, which I will love to give you as a PG student, you guys.
Hello everyone, I'm Dr. Sana Farishta, periodontist and laser specialist, and today I'm going to showcase you a case of restorative crown lengthening. And for this I have selected S1 triple wavelength prion laser, and I'll be using 980 wavelengths for the same procedure. Before we start the procedure, first very important step is to measure the biological width by bone sounding method. We will select 980 wavelength and 400 micron tip. So we will divide the surgical procedure into 3 simple steps. Step 1 is, at a low wattage, we will pre-mark the tissue which has to be removed in a form of dots. Step 2 is we will connect that dot and increase the wattage a little bit because we need an incision there. And step 3 is the crevicular incision, which goes like this, and we will relieve the entire area and we will remove the tissue which is required to be removed. And that's how we will do a soft tissue crown lengthening procedure.
Yeah, so I was talking about this closed flap osseous crown lengthening procedure, which has been published here, and Balaji sir is also a part of it. So I'm glad. So this is my case, and I'll tell you guys, every week I do this kind of a case. Every week, maybe 1 or twice. So very important is I did my aesthetics, and so that's why I have a lot of knowledge about Galib-Gurel principle, the golden proportion and all. And we do measure the Galib-Gurel principles over here. We take an impression, make a cast over here, put a stent, and then with a hard tissue laser, I just pre-mark the area which needs to be removed as a gingivectomy. I did my gingivectomy. I'm showing the first 2 central incisors. And then you do your bone sounding. You can see in the first picture, the moment I'm putting my periodontal probe, you can see blanch over there. Just a second. Can you see blanching over here? Right? And this is after my osseous crown lengthening. So I did the entire osseous crown lengthening with my hard tissue laser without raising a flap or without suturing, because this is non-invasive and none of the patients want that aesthetic area. They are going for laminates or any kind of a procedure where we give sutures, wait for the area to heal, and so on. So I'll show you a short video of me doing this particular case.
एक दो वीडियो में मेरा फेस भी ले लेना, लेकिन मैंने चश्मा नहीं पहना। पता तो चले कर कौन रहा है। शुरू की वीडियो में है तो क्राउन लेंथनिंग का वीडियो। अब जी रुक जा, लास्ट करने से पहले चश्मा पहन ले। हो गया।
So I'm using a probe. Very important is because it's a blind procedure, and probe is the only thing which I use to guide myself. This is when you ask a patient to smile during smile designing, you will find in a lot of cases the canine roots are a little exposed as compared to the centrals and the lateral, and particularly on the canine area. And when you're doing a smile designing, you don't like that area. So what you do is I do a semilunar flap with my laser. I give a partial incision over here and then bring down the entire. I'm also using scalpel. In this, both the cases, what I'll show you, the root coverage, I have used laser as an adjuvant. So for a clavicular incision over here around the teeth, I'm using a scalpel. I relieve it, little bit loosen it, and make sure that it attach from the papilla area, and then bring it down and apply a periodontal dressing. Let it be there for 10 days, and that's how it looks afterwards. Okay, little better so that I can plant my laminates in this case if I want to. Another is bridge flap. Okay, guys, not to exaggerate, but yes, this case I was doing in my first year of PG, where you are not even allowed to do a flap surgery. But yes, because I was so, and I was the first batch, by the way. So we got a lot of chance to do a lot of things. So what I did is here I have used laser for a vestibuloplasty incision, right, lower, and in the upper areas I have used my scalpel. Yes, one of the PG student from Mumbai, she is doing this as her thesis, taking my article as a key article, and that's how it is. And then we suture it, pull it up the entire gingiva, we suture it, and below you don't have to give a periodontal dressing or anything, not even suture, because I've used laser for the vestibuloplasty. Sorry, please maaf kar do periodontal dressing ke liye. Mere guide ne to already chillaya tha, pehli baar de rahi thi dressing, so it was like that. But that's how it is. Then this is before and after. Lip depigmentation, yes. So now whatever the studies whatever the articles, whatever I'm gonna show you is I'm the first person to come up with this publication. So if you guys want to read about my publication, you have to go to www.drsana.in. I repeat, www.drsana.in. Go to the research column, download all the articles. If it is not able to download from the PubMed, you can download it from my site. And very important, still I would like to thank my patients over here. They are the interns when I was doing PG final year, and they were my interns who underwent my lip depigmentation technique. So both the interns, I still always thank them that they have trusted me. And yes, all my cases, what I did after that, it has been done on dentists only. So this is what Rishabh was complaining of, and we did it for him. We did a laser bandage followed by it. That's how it looks, because then the skin will peel off, and that's how the final is. And there are a few more cases. You will find it in the article. Now, the lip repositioning with laser. So we call it as laser-assisted lip repositioning surgery. Journal of Indian Society of Periodontology 17. And you will find my second publication, which is a modified version of a lip repositioning surgery, which will be published very soon, maybe this year or next year. It has been accepted. Thank you. After so much of mehnat. Yes. So this is how it looks. I also did a little bit sculpturing or gingivoplasty with the central incisor. If you see here, because the zenith was not equal, and my whole criteria to treat this kind of a patient is for the better aesthetics. So what I did is I marked it exactly like we do it with the scalpel, and remove entire tissue and suture it. So this is after, before, and after, and that's how it looks, right? So now, always in all the cases, there is a relapse. Of course, in this case also there was a relapse. And to avoid the relapse, not 100% relapse, but of course, a little bit relapse. So to avoid the relapse, I came up with a second technique. And in that technique, there was again 10 to 20% of the relapse. So I'm working on the third technique where, inshallah, there's no relapse. So what not to do, which is very important. Now you have seen what to do, what not to do. I'll show you. So this is a crown lengthening case done by one of my participant only, who maybe heard me for an hour, or maybe who have attended my session for one day, which usually doesn't work. You need a entire intense training when you want to work on lasers. With lasers, like the way I work with lasers. So here what she did is she scraped the entire gingiva, and this is what this crown lengthening they did, which is not good. So yes, another thing is this. They promised the patient that they will not inject. In the middle of the treatment, the patient was finding it very painful, and then they have to inject, and then patient refused to go ahead and do the treatment because of the false promises. So make sure that you don't promise your patient anything like that. Yes, again, it is operculectomy, which is like overextended, and little bit more wattage was used. So the temperature of the tissue looks very naughty on necrosed. Yes. Another thing is that, yes, done by a very famous periodontist who doesn't believe in laser, and we gave the laser to him for the trial, and he returned it to us by saying that the laser doesn't work. But if we do this kind of a procedure, of course, laser doesn't have brain, and person doing it has to use their brain. So that is the thing actually. And it took 20 days to heal like this. And patient was on painkiller and antibiotic, and patient was so against with laser. So my humble request to everyone, if you really want to use laser, please learn laser, because it's not easy that you think that Acha, aaj sun liya, kal main kar lungi. No, it's not like that. It's hell lot of calculation, and you need to spend a lot of time to learn it. Yes. So here I finished my presentation. Very important is you can connect with me on Facebook. Sana Farishta 12344 4 is available. Facebook group is Dr. Sana Farishta courses for all the courses. Our page Divas in Laser, and please appreciate all my divas. They are doing wonderfully well in their career. And yes, those who are interested in my personal life can ping me on Dr. Sana Farishta, and the other ID is my clinic ID. Leave it. And website, yes, www.drsana.in. You can find your articles over here. You can download, and you can contact us on this number. No stupid messages, please. Yes, and this is the fellowship program. University. It is 1 year, and any one of you are interested, you can opt for it. An idea. Thank you so much. I'm up for the questions.
Thank you, Dr. Sana, so much for this lovely presentation. Okay, see, as expected, presentation was lively. Okay, lively like you, right?
Thank you.
So yeah, so but only difference which I find when a person like me gives a presentation, a person like you gives a presentation, is that when I gave a presentation, there were hundreds of questions. So probably that I didn't give the presentation that well. So there were so many doubts in the minds of the listeners. But what I find is that I've got very few questions. Probably the reason could be that you made the thing so clear for everybody that they hardly had any doubts in their minds. But whatever questions I have got in the chat box, I'll just share with you.
Yeah.
There are three questions that are there with me. One has been asked by Dr. Rajsekhar. And the first question reads that, what about the cementum injury due to diode laser during LANAP?
Actually, I'll tell you, it again depends upon the wattage. So what wattage you are using. Very important is the calculation. If you use the power setting is more, there can be injury to any part of the gingiva. Can be injury to periodontal ligament, because that is more vulnerable than cementum. There can be injury to anything. So very important is what wattage you are using. So if you see, laser is a दो-धारी तलवार. अगर आप उसको ज़्यादा wattage में use करोगे, oh, I can see Gopinath sir. Hi sir. So if you use in ज़्यादा wattage, then what will happen is you will do harm than a good effect. So controlled, in a controlled manner, it's good. Otherwise, if you, it's all depend upon the wattage. So make sure that you use less amount of wattage. So what I follow, okay, I will give him the wattage what I follow by Donald Colusi. So first step, you will use 0.4 watt, and second step, you will use 0.6 watt. Remember, I'm always playing with point wattage. So if you do in point watt, there's no damage to any of the tissues. Yes.
That's right. Now, second question again from Dr. Rajsekhar only. Now, he has asked that how do you control the depth of laser during depigmentation?
Very important that it's like a light brush motion, right? So you remove layer by layer, layer by layer. And all this you will learn with dexterity, right? You can't if we talk about modified bars technique, if you want to brush modified bars technique, you can't go ahead and go ahead in your room and you start brushing like modified bars in one day. You will find little difficult. So it comes by practice and training. But yes, always remember, start with a low wattage and brushing stroke like this. Dheere dheere, remove epithelium by epithelium so that you can see it. And of course, you will just reach the connective tissue, maybe remove a little bit of connective tissue, and you stop there. Okay. In the first case, if you find this difficult, you can do till the time you are comfortable with it. And till the time you feel, okay, I'm not inside the connective tissue much, call your patient again for a revision surgery. Okay. So whenever you guys are doing your first or second case, tell your patient that it might require 2 sitting, it might require 3 sitting, and take your own time. Do it slowly. Okay. Ask the patient will come for the second sitting. Now you will understand in few areas you will see pigmentation. In few areas you will not see pigmentation. You will understand, okay, in the areas where I'm not seeing pigmentation, how I was doing? Okay, how much was my depth? And you have to evaluate by yourself. There is no funda or a protocol or a, Alibaba ka pudiya that I can give you. Okay, aise hi karna, sana ne de diya, aise hi hoga. Okay. So it's all your experience and you get your own experience with it, right?
Okay, so Sana, next pudiya from the listener side is that what kind of healing is achieved after laser periodontal surgical therapy?
Yeah, so it's not a primary intention healing, of course. And I can say it's not exactly a secondary intention healing, it's actually laser healing. Yes, if you increase your wattage and if you pura area ko necrotize kar dete ho, then of course it is a damage and it is a necrosis and it is worse than secondary intention healing, which you have seen maybe in a lot of cases. And that was my first question when I entered PG as a periodontist. My first question was, everybody told me, laser has a delay wound healing. Laser has a delay wound healing. So what I do now is, after my laser, I do a laser bandage. So laser bandage, what it does, it increases the healing. The healing is better than scalpel. Why? Because laser bandage proliferates the fibroblast. So what is the first line of action when there is a healing? First cells which come into picture is a fibroblast. So more fibroblasts, more proliferation, more healing, a faster healing.
Okay, so now there are a few more questions that are pouring in right now.
Please go ahead.
Somebody has asked regarding the mechanism of diode lasers.
Mechanism of action, how it works.
Diode lasers.
So yes, so it's in, see, I can talk about mechanism for a day, but keep it very short and simple for you. Full form of laser. So whoever has asked me can just write it down. What is the full form of laser? Light. Okay. Rather than I'll answer. Light amplification by stimulated emission of radiation. So this stimulated emission of radiation is the mechanism of action of diode laser. Yes.
So there's one question by Dr. Shagufta that she has asked, keeping in view the COVID-19 situation. Okay.
Yes.
Question is simple. That she has asked that why? What about the sterilization part of the laser tip, especially because of this COVID-19 situation?
Yes. See, sterilization has to be taken care whether it is COVID or not. Very important. Now people started putting effort on sterilization after COVID, but people like me, those we are working, we are putting efforts and also pressure on sterilization the day we started working, right? So very important is, I use a hard tissue laser in this COVID situation, and I say that the hard tissue laser has a lesser aerosol production as compared to the burr, which is very true, right? And the hard tissue laser tips can be sterilized. There are options of sterilization of tips in diode laser also. So it depends upon brand to brand, which brand machine, which brand laser you're using. So few brands give you option to sterilize their tip. Few brands give you option not to sterilize their tip. It's up to you. You can use it. There are disposable tips also. Use and throw, right? That's how we do it.
President ma'am, do we have some more time to ask questions?
I'm all yours.
No, I have to take permission from President ma'am also.
Yeah.
Nempia ma'am.
Madam ka hukum sir aankhon pe.
Okay. Ma'am, unmute yourself.
मेरे को
You
तो
are
मैम
mute.
दिख ही नहीं रही है.
You are mute, ma'am. Okay, chalo, anyhow. I'll just ask.
Ma'am, you are mute.
I think he has
अच्छा
done so.
आपने ही म्यूट करके रखा है क्या मैम
No,
को?
no, I can. Yes, ma'am. Nempia
Okay.
ma'am.
No, I think 5-6 questions are enough. Then she can give her email address and they can
Okay.
ask on the email.
Chalo, I'll end up the question session with my question. I had a doubt, Dr. Sana. You must have attempted few biopsy cases also with the lasers.
Yes.
You have done? Okay.
Yes.
Now, my question is that does it alter the tissues that the pathologist they ask that?
Yes. Very nice question. Very nice question. So what is important is whenever we remove, let's imagine I'm removing a fibroma. So if I'm removing a fibroma with my laser, what happen is the entire margin will be burned. Right? Okay. With the scalpel, there the margins is intact. So I'm talking about the specimen. I'm talking about the lesion, what you remove. So the removed lesion has a margin which is burned. Right? So it is very important to mention when you're sending it to pathologists that this has been removed with laser. I remember in my first case, I have not mentioned it to a pathologist and he has given me a haywire diagnosis. So very important that you mention it. The lesion has been removed by a laser and that's why the margins are burned. That's it. This is the note that you have to give to your pathologist and they are smart enough to do the further findings.
Okay, so as asked by President ma'am, Dr. Nempia ma'am, so we finish with the question answer session also on a very positive note saying that Dr. Sana, you have been as I've heard, a great speaker. It was a wonderful presentation and you are really a lovely person. And I hope everybody has enjoyed your presentation and with a suggestion to all the students, especially if you have got any questions, Dr. Sana has given her contact details. Of course, you can contact her.
Yeah, that's my team actually. That's my team.
And as she said earlier, with of course, no nonsense and all that. Okay.
Yes.
So thank you so much,
You're
Dr.
most
Sana,
welcome.
for being here on this
thank you
platform.
so much for the wonderful introduction. I really loved it. I'm like hungry for, appreciation. So I loved it. And I can see Balaji sir. Hi.
Hello. Hi. Very refreshing presentation. So many those webinars which were very boring.
Thank you, ma'am.
If we people invite you to Chandigarh side, that you'll agree to come.
I can send my team also.
You have to pay her because she works till 1 o'clock. You have to
money. There's nothing without money.
1 o'clock.
That's what. Okay. So thank you so much, Dr. Sana. Thank you.
Thank you so much.
I know you have to get ready
Thank you, ma'am. Thank you so much. Thank you, guys. I have to rush to the clinic. Thank you.
Thank you, the ISP head office, and special thanks to the audience for sparing your valuable time also. Thank you so much. Thank you, all of you.
Thank you. Bye, guys. Bye.
God bless all of us. Thank you.
All of us. Inshallah. Ameen. Bye.
Shall I end the meeting, sir?